So, hi everybody, my name's Della, as Eva said. I'm a midwife over at the Manchester Sickle Cell and Thalassemia Centre, for those of you that don't know me. I work with a team of people who some of you may or may not know. So basically a quick rundown is there is myself and Jane, another specialist midwife. We take care of the antenatal and newborn side of the NHS screening programmes. Antenatal newborn, that is. We have some adult counsellors, Fiona and Grace, that do all the adult counselling and looking after our adult patients. We also have a paediatric care for children with haemoglobinopathies, in particular sickle cell and thalassemia. My job closely interlinks over with the antenatal clinic. We are a huge trust in Manchester, spanning I think 5 or 6 hospital sites. There's a lot of kind of shared working going on and a busy pathway there to oversee. So I've not done a slide of aims. I think the main aim of today is just to tell you a little bit about what I do, and for people that don't work in midwifery, just to give you a bit of insight as to what happens on our side of things. I often get asked, it's interesting to know how people feed into services or how they get there and what goes on behind the scenes. So it's just literally a few slides today to tell you a little bit about that, and I hope it's helpful. So, the antenatal programme standards are set out by NHS England, are very strict standards on how the pathway should be delivered to pregnant women and babies. When offering screening to our cohort, it's very important that, and it's a programme standard, that women are given this publication called Screening Test for You and Your Baby. That is available as a leaflet or a booklet. We also have the QR code. It's online in lots of different languages. And the point of that really is that at no point in anybody's life, other than in pregnancy, do we kind of step in and out of so many screening programs. You literally go from one to another. So, you know, people say they're bombarded with information. There's too many tests to think about. They don't necessarily understand the implications of the test. They end up agreeing to things that they probably wouldn't have they ever understood it. So it's really important, we say, that women are given this information before they ever attend their first appointment, so they understand what they're signing up for. A couple of pages in that document are specific to screening for haemoglobinopathies in pregnancy. They are it's universal screening, so everybody is offered screening in pregnancy for those. It's an opt-in or opt-out. You don't have to have it. It's not recommended, but it's there as an option. So we hope that women are able to look at that before they come along to the appointment, so that when they consent on the day, they're not under pressure, and as I say, they know what they're letting themselves in for. There's lots of useful information contained within that document. I know in Manchester Foundation Trust, we send this out as a QR code when we were sending letters or text messages, so that people can access that really easily and really at ease. So all pregnant women are offered screening for haemoglobin variants in every single pregnancy. We sometimes get some confusion with this, whereby we used to see if people had a previous result, i.e. your status doesn't change. So there was a misunderstanding that if we had a documented result, even if it was from 5 or 6 years ago, we would use that. That's not the case. We recommend that women are screened in every single pregnancy, regardless of any previous results they may have. There's a few reasons for that. It's a safety issue, really, and it's to cross-check information that we already have. It's probably not an unnecessary blood test, because we know that women are having lots of blood tests for lots of different reasons. So it's not, you know, an unnecessary venipuncture by itself. We also have, say, for instance, over the years, thresholds changes and reporting changes. And we do sometimes get results which are slightly discrepant from other results, and they always need looking into. So it is really beneficial that we have a sample in every single pregnancy. And if you're thinking, what does that mean? What is that? I'll just give you an example. Last week, we had a pregnant lady come through who had 3 previous children at the same hospital. She had the same partner. In the very first pregnancy, there's not a huge pregnancy gap between all 3. So in the very first pregnancy, a haemoglobinopathy result came back to say that she was not a carrier of any haemoglobin variant. Her result was AA with no evidence of thalassemia. In her second pregnancy, a couple of years later, she had another result to say that she was suggestive of alpha thalassemia, which is, you know, based on her ethnic origin, wasn't really of much significance. That was different from the first one, and we had to explain that. Third one, again, reported the same as the second one a year later, so that was fine. This pregnancy, she's had a test, and it's come back to say that the test is suggestive of beta thalassemia, which we all looked at it and was like, what? Anyway, on delving a bit further into this and asking, we thought at first it might just be an error from the lab report or a typo, but it transpires that she has a raise in AF2 level. Now, 2 years ago, the level that it was at would have not raised any suspicion about her carrier status, but based on further evidence and further lab standards for what their cutoffs and thresholds are, we now think there's a small possibility she might have an underlying beta thalassemia, which can sometimes be difficult to detect. So we've offered her, we've offered her screening for her partner, and we're going to do some DNA blood testing on her just to rule out an underlying beta thalassemia trait. So, you know, it's a very rare instance and it's unusual, but, you know, it was helpful in this scenario in getting the best information for the woman at that time. The standards also tell us that results must be made available to the patient by 10 weeks and 0 days of gestation. Screen positive results will be actioned within 5 working days by the Manchester Sickle Cell and Thalassemia Centre, i.e. me and Jane. That's not actually an NHS England standard, that's a local protocol and agreement, but we aim to get back to women with results after 5 working days. Partner or father of the unborn baby would then be offered screening in line with national guidance to ascertain the risk to the pregnancy, if any, and pregnancies identified as at risk should be counselled for further tests and offered those couples. I'm not sure if someone else is moving the slides. It might be accidental, but never mind. And then pregnancies identified as risk, will be counselled for prenatal diagnosis, ideally by the standards by 12 weeks and 6 days of gestation. So yeah, I thought it might be useful just to list a few barriers we come across as screening midwives to meeting and achieving programme standards. We're performance monitored against all standards, and we're required to submit that data quarterly to NHS England. It's not as easy as it's set out to be, and these may be some of the reasons why. So the first standard, whereby women should have a result reported by 10 weeks and 0 days, kind of depends, you know, or relies on the fact that women access antenatal care very early, and that we're able to get them their first booking appointment, and that we're able to obtain the blood sample and get a result by the time they're 10 weeks pregnant. Now, you know, we've had previously a lot of women coming through that have struggled to get an appointment. It's a very busy hospital. You know, their referral ends up in a pile at the GP surgery somewhere and isn't quickly actioned. And just to the sheer volume of the women have coming through that are pregnant, that sometimes, you know, they are waiting weeks for an appointment. So they may present early but not arrive within the service early. So we are really dependent on women presenting really early for antenatal care, which I appreciate isn't always, you know, easy. We do now have the online referral service across Manchester Foundation Trust, which cuts out the middleman, so to speak. It stops women have to go into access us through a GP. So we're hoping that as we continue to produce data each quarter, that we hope that that does have an impact, a positive impact. Discrepancies with results. Sometimes we get women who have been screened elsewhere, or who don't want to be screened. We may have a different result from a result that they've got. Usually they've not been screened in the UK. It's unusual we get a discrepant result from the UK. And it's about, you know, counselling and going over results with patients and understanding the need for rescreening and why we can sometimes get different results. Sometimes if we think about the second standard, referring, you know, women for prenatal diagnosis, we need to have an available partner result. Sometimes, or, you know, often actually partners are not available for screening. So that could be for a multitude of reasons. Sometimes it's because you know, people are in jobs where they have 0-hour contracts, they can't get away for appointments, they work far away, they don't live in the city, you know, they sometimes don't live in the country, or they're just not available for whatever reason. So, you know, to be able to class someone as a high-risk couple, we need a result from both, and it's not always easy to get hold of partners, which can sometimes, you know, delay timeliness of results. Partners having results from another provider, sometimes we have to explain. We often meet partners that say, oh, I've been tested here, or I've been tested there. That may be in the UK or out of the UK. Sometimes they don't know where to locate that result. Sometimes they have to ring a GP to get a result, or another clinic or another hospital. Sometimes they have results from abroad that they have to, you know, put their hand to. They don't know where they are. They don't know how to get hold of them. Or sometimes them saying, it's okay, I've been screened elsewhere, I don't need to be screened again, and us trying to explain the importance of us having a result to be able to be 100% sure about the advice that we're giving, which can, you know, again, has to be worded really carefully, and we have to be careful we're not playing it down, you know, that people have done their own tests, but for the safety of the pregnancy and for classifying things, we like to have a result in a UK accredited lab that we can see and that we can visualise, just to be sure about the counselling we're giving. More recently, I thought this was an interesting one to put in, the cost of living crisis, issues attending appointments. We see now more often than we did before. We're a central Manchester location. We cover a massive geographical area. We have in-house referrals from, you know, five of our hospital sites across Manchester and Greater Manchester, but we also have referrals from outside of from elsewhere in the region. You know, some people tell me they can't afford to keep getting buses and trams, you know, they can't afford to take the day off work. So as well, for midwives, it's about working around that and finding ways around it. We are doing a few more home visits now, or trying to accommodate people at other appointments. So it may be, you know, we're all about time pressures and getting these done tests quick because of the standards, but on a practical level, sometimes it means saying, okay, you can't get here, I can't get to you. When is your next appointment with the midwife? They may say, well, that's in a week or in 10 days. Is your partner going to be there? Should I come along to that appointment and see you there if that's the easiest thing to do? So it's all about improvising and finding ways around things and doing it, you know, as quickly as is physically possible. Difficult decision making. Again, sometimes couples are not aware whether they want further testing. They get a result they don't expect, or they just don't quite know what to do. So it's okay giving people timelines, but it's decisions they need to make for themselves, and we have to allow them the time to do that, because they have to come to conclusions that are right for them, not for us. And also another hurdle we get sometimes is being unable to secure timely appointments. So for women or families that opt for prenatal diagnosis and want that further testing to confirm, we have to then contact our fetal medicine unit, which is a tertiary unit. Again, they have a massive, you know, cover a massive demographic area. I think from all the way up North Cumbria down to Liverpool. So sometimes securing appointments for those tests is more difficult than we first think, and we can get somebody referred in a timely manner, but we might not get an appointment for 7 or 10 days, you know, which then may further delay things. And again, that is sometimes out of our control. When we talk about screening for conditions, I won't go into, you know, all the possibilities. There are many, but, you know, we're picking up sickle cell trait or disorder, beta thal trait or a disorder from antenatal screening. Now, usually women living with a significant haemoglobinopathy will know about it. They're usually in treatment themselves, you know, or they've been poorly, they've had crisis and they've accessed treatment elsewhere. We have occasionally picked up something like, you know, SC disorder or something where the patient claims they were not aware. So yes, we do get the occasional, you know, result that surprises us. A lot of women that we contact don't know they were a trait or carrier of a gene. It's the first time they ever hear about it when they're pregnant, so that can sometimes come as a surprise. Some other people say, oh yeah, I know about it from a previous pregnancy, or I had some bloods at the GP when I was a child, or my parents always told me, and that just varies across the board. We will also pick up haemoglobin variants C, D, E, F, and all different types, which the lab will classify as, you'll see it on a report as AX. You know, it can be anything Philadelphia, Silver Springs. There's just too many to put your hand to, but we pick up all sorts from antenatal screening that we end up discussing with patients and the significance of those. Counselling, will be specific to the patient result. Sometimes this can be straightforward for us as midwives. We know that if two people, carry a beta thalassemia gene, we're able to adequately counsel and tell them about what the potential outcomes are for them and their baby and what the risks are to the pregnancy. Sometimes if it's more unusual variants, we might not know off the top of our heads. Well, Jane does more than me because she's been in the job way longer, but it might not always be at our fingertips. We might have to ask the team for an opinion to say, does this interact with this? Mum's this, dad's this, what does this mean for a baby or for a child or a young adult? And it's our job then to relay that back to the patient and give them the most up-to-date information. So a summary of the counselling we give then really is results are given usually by telephone rather than face-to-face, although sometimes we do give face-to-face results. Sometimes if there's a language barrier or communication difficulty, sometimes we do bring people in for a face-to-face chat if we think that that's going to improve the way that we, deliver the information. We explain the significance of that particular variant, both in the trait or the disorder form, so that kind of to plant the seed that if this couple do need, testing in the future, they kind of know what they're being tested for. We also provide them with publication documents from NHS England about that particular disorder, so they can have a look and decide what it means for them. Discuss partner hemoglobinopathy status. So one of the questions we ask when we ring a pregnant woman to tell them about a result we've detected is, do you know if the father of the baby or your partner has been screened before? Sometimes they know that information, sometimes they don't, sometimes they need to go away and ask, sometimes we need to chase it up. Again, it varies. Some people will say, yes, he's definitely been tested, you should have the result, you did it, in which way we can kind of work out that then and calculate that and kind of sign those things off. We give a brief outline of the benefits and risks of partner screening. So sometimes we'll discuss a result with a pregnant woman and they say, oh, I don't think my partner's going to want to test. I don't know what we're doing that for. And it's kind of just to inform them and make them aware. Unless we know the status of the father of the baby, we're unable to kind of let them know whether there's a risk to the pregnancy or the baby. So it's just so that they understand the significance of that. We give a brief outline of the pathway in view of a screen positive result of the partner. So we do try to not go too far down the line, bombarding people with information, because we kind of make it clear, if the test comes back to show your partner is not a carrier, then we know that there isn't a risk to the pregnancy. However, if it does, we give a brief outline of what the next steps will be, because that is often on people's minds. They need to know kind of where this may allude to, or we may be able to close the screening loop and finish the screening if the partner's not affected. I do ask for a bit of a family history. I always say, is there any family history of sickle cell or thalassemia or whatever it is? Anybody in your family affected? Any information? And also asking about the partner. Does he know if there's any family history on that side? Again, that is not definitive. It's not diagnostic. We have, people carrying the trait throughout a family and nobody knows about it. But it would kind of be a bit of a flag if they said, oh, well, actually, yes, my partner hasn't been screened, but his two nieces or nephews have sickle cell. You'd be thinking, okay, so this potentially might be an at-risk couple. We then, at the end of the consultation, exchange contact details. As I say, we send out a link for the relevant information as given by NHS England, and we offer an appointment to screen the partner where necessary. If a pregnancy is identified as being at risk of a significant hemoglobinopathy disorder, the couple are then informed of the results as soon as possible. Takes us about, I usually say, a couple of days to get a partner result back. So, if we do the test on Monday, say kind of expect a call on Wednesday, Thursday, we'll let them know that it's come back and what that means. We discuss options going forward. At this stage, some people have already had a chance to think about what they might want to do if the partner comes back screen positive. Some people just say, okay, now I know, I'm going to go and have a think about it, and that varies. We do further and more in-depth counselling about children or young adults living with that condition, because I think that's important in them making decisions as to whether they may want further testing or not. We discuss benefits and risks of prenatal diagnosis. We book an appointment where indicated, so if somebody is sure they want a definite answer, after we've given all the information, we book that appointment and sort that out on their behalf. We will also at that point need to obtain what we call DNA bloods from the couple. So although they've already had their blood test done, it's just explaining to them we know you've had tests and we know the carrier of this gene. However, we now need to do some more detailed testing, and that will help the lab when they test the amniotic fluid or the placenta to know exactly which gene mutation they're targeting, and that will speed up the results. So the risks and limitations of prenatal diagnosis, we say, so as of yet, there is no provision for non-invasive prenatal diagnosis or non-invasive prenatal testing. So pregnant women are receiving a lot of information now about different tests. And as some of you may know, for example, with trisomy screening and Down syndrome, women can have blood tests to tell us whether the baby has a condition or not. So we often get asked, do we have to have an invasive test, or is there a blood test we can have to give more information? And the answer to that at present in testing for sickle cell and thalassemia is no, we don't. We discussed the procedure-related risks of miscarriage. So what we say is there is between a 0.5 and a 1% chance that if you have this test, there may be a procedure-related complication of having it, which unfortunately means that you may miscarry or lose the pregnancy just because you've had the test, and that is regardless of the result. So that's kind of phrased like, if we do this test on between 1 to 200 women, unfortunately, regardless of the baby's hemoglobinopathy status, one woman would lose the baby because we put a needle inside the uterus. So it's making sure that they understand the risks, and risks, you know, are very subjective. I meet couples who, you know, have struggled to get pregnant for 10 years and they're not going to take any risk whatsoever for the pregnancy, regardless of the percentage. I meet some families who say, we already have a child with thalassemia or sickle cell, and you know, we're going to accept that 1% risk against the 25% risk that the baby has the condition. So that's a very personal thing, and that's specific to the couple. We also let them know that even though we can undertake and do the procedure, there is a small chance that we might not get a result. Sometimes the lab contacts us to say that it's very difficult to obtain a result. The result may be, the sample may be blood stained. They just can't get enough DNA from the sample, and there's a risk that we might not get a result after undertaking the procedure. We sometimes we may be unable to obtain a sample due to technical difficulties. So we kind of prepare people to attend the appointment. The procedure itself, the needle going into the uterus, the doctors have to be very careful. They can't go anywhere near the baby. They can't go anywhere near the bowel. They can't go anywhere near the bladder. And the placenta, if they're going into the placenta, has to be accessible. And there's a chance that, you know, for one of the reasons I've just said, we can't get to where we need to get to obtain the sample. So, you know, we may wait 2 weeks for an appointment, get there, and on the day we can't do it, which is always really frustrating for everybody involved. But, you know, for safety can't be helped. And if we don't get a result, or we can't, you know, get to the placenta or the amniotic fluid, then we may need to repeat the procedure and bring the patient back. By saying PND, I'm talking about diagnosis, that's done 2 ways. It's either by what we call a CVS or a chorionic villus biopsy or an amniocentesis. The procedure itself is pretty similar, other than one goes into the placenta to take some placental villi, which the placenta is derived from the egg and the sperm. It contains the DNA of the baby, so we can get results from that. The amniotic fluid that the baby swims in after 15 weeks contains the baby's skin cells, and within the baby's skin cells, the lab can analyze the baby's DNA. Now, we all know, depending on the gestation of the patient or how easy, you know, accessible, depending what the scan shows, the doctor will discuss that with the patient on the day about which one is best. So CVS from 11 weeks onwards, amnio from 15 weeks onwards. Sometimes we do rapid testing for trisomy Downs, Edwards and Patau's. We get those results within 2 to 3 working days if the patient wishes to add that on. Testing for sickle cell thalassemia or hemoglobin variants usually takes about a week. Sometimes there can be a delay with that, particularly with amniocentesis. It just depends how long it takes the lab to extract that DNA and derive a result. The procedure is always undertaken by a fetal medicine consultant or somebody at the same level with adequate training, and the procedure is done under ultrasound guidance so we can see where the needle is going. The procedure itself probably takes 10 minutes. Women usually sit down for half an hour afterwards with the midwife, and as long as everything's okay post-procedure, we advise that the patient goes home with safety netting advice, which is to rest, to watch for any signs of infection or any sign of pain and bleeding, is to attend the emergency gynae department and get a doctor review. So the potential outcomes then from prenatal diagnosis would be dependent on the genotype of the parents. And by that I mean we do a lot of counselling beforehand about the chances of inheritance. So if the mother, for example, has sickle cell disease and she can only pass on an F, the risks will be different to two parents who are both carriers. And we need to go through that before and make sure the parent understands exactly what the inheritance risk is. Depending on who's doing the counselling, we use things like genograms, charts, visual aids, just to help them understand what those risks are. So there's a chance, say, for example, if both parents are carriers of a HBO disorder, that there's a 1 in 4 chance in that case that the baby might not even be a carrier, so not even be have a carrier status. There's a 50% chance that baby could be a healthy carrier like mum or dad, so beta thal trait or AS or whatever. There's also a 25%, a 1 in 4 chance if both parents are carriers that the baby could actually have the disorder, and that's what the test is trying to determine. And we'll be issued a DNA report to show us whatever, all of those outcomes would be displayed in the DNA report. In the instances then of an affected pregnancy, I find that often, even though the result may be anticipated, everybody that's going for that test knows that there is a risk that could happen or they should do. Sometimes couples still need time to consider the results and the options. So you give the result and they say, well, we really need to go and think about this now we know for sure what we're dealing with. Some are already aware of which path they may take when you call and they say, right, let's get things moving one way or another. And the options really are to continue with the pregnancy with an awareness of what, the condition the baby has, or to make the difficult decision to end the pregnancy and terminate the pregnancy and not continue. I find that many parents opt for early testing so that early termination of pregnancy can be facilitated wherever possible. That's not to say that it's easier to make a decision whether you're 11 weeks or 15 weeks or 20 weeks, but we do know that as time goes on, these things seem to get more difficult for parents. So we try, and that's the whole thing about the timeliness and trying to get results as quick as we can. The pathway then for termination of pregnancy, it can depend on which hospital the woman has accessed antenatal care. It might be specific to the trust that she's come from, depending on the gestation. We've got a diagnostic report, it would be signed under what we call Ground E, certification Ground E, which has to fit the criteria that there's a significant risk of a child suffering physical or mental abnormalities if born. So we need 2 doctors to agree that the disorder is significant enough to cause one of these things, and then 2 doctors would sign, and we would be able to undertake the termination under what we call Ground E. Patients can choose medical or surgical termination, and we'll go through the risks and benefits of both of those, and it's a patient choice. For later gestation terminations, which is really difficult, feticide may be required if the gestation is above 22 weeks. We've kind of said that before. On a local agreement in Manchester, the agreement is that termination will be offered up to 24 weeks of pregnancy at age of viability. We don't do late terminations usually, but if there was someone really strongly requesting that would be discussed in a separate meeting with the multidisciplinary team to see what the consensus was. But as a general rule, that's kind of how we mark things in view of timing. We do get some parents asking to speak to specialists prior to making a decision. So we have had people go and speak to, say, paediatric consultants to talk about children, with a similar clinical presentation and what to expect. And they need to do that in order to aid their decision making, and would facilitate that wherever we can. I thought we'd just put on a couple of case studies just to kind of put into perspective what we discussed today. And the screening midwives are always talking about timeliness. I put a lot of emphasis on timeliness, and I hope that these couple of cases just kind of show why we do that. We understand all the things that impact things, why we can't do timely, but this is kind of why we're really, really pushing to get people in and screened early. So case study 1 was a woman who booked for pregnancy care at 13 weeks at her local hospital. It wasn't a Manchester hospital. She had her pregnancy bloods done in line with the screening programmes, which included screening for sickle cell and thalassemia. The relevant history associated with this lady was that she already had a baby who was 2 years old. This baby was born in the Caribbean, where at the time the couple were both practicing doctors. She'd reported to the midwife at that time that she'd already had screening, but later on that it transpired that she hadn't had screening for beta thalassemia. There they were just screening for sickle cell in the hospital where she'd been, and that wasn't made clear to her, so she wasn't even aware that she was a carrier. The family origin questionnaire, which is completed with every sample, indicates that both her and her partner were both from Southeast Asia. Her blood sample was analysed and reported the following week, when she was 14 weeks pregnant, that shown that she was a beta thalassemia trait. Partner was offered screening a week later in line with local protocol, which is the right thing to do. He was also screened and found to be a carrier for beta thalassemia. There was then some sort of pathway delay in her being referred into the Manchester Sickle Cell and Thalassemia Centre down to some confusion, which was human error, meaning that by the time we met her at the centre, she was already 18 weeks pregnant. The couple were both doctors and had a medical background, so what made the counselling slightly easier was that they had awareness of the clinical significance of living with different types of beta thalassemia. They were worried about having a child with a significant illness or a child that might require lots of treatment throughout life, potential hospitalisation and intervention, and that was on their mind. They expressed that that was a concern of theirs. The gestation at this point was rapidly advancing. If you think about the timelines that we've discussed, they've got a lot to consider, they've got a lot to think about, and time is not on their side. The couple had described being in a moral dilemma. Although they thought that they would never consider termination as an option regardless, they were worried about the impact that this would have on them and their other child, their daughter, and the fact that they were both, very busy lifestyles and schedules, and they were worried about what they would do if they had a child that potentially might be sick. After some thought and consideration, they decided that they would need more information to be able to decide whether they would like further testing. So we brought them in and did some DNA blood testing on them both, and it was they wanted to know what type of beta thalassemia they carried, because how that may present in a child, and that was important to their decision making. So we did DNA bloods. By 19 plus weeks pregnancy now, we had DNA reports on both of their bloods showing that mum and dad were both heterozygous carriers of beta 0. The clinical significance of this, as stated on the report, was that any children that they had would have a 1 in 4 chance of inheriting beta thalassemia major. This was a massive blow to the couple. It was what they kind of were worried about, is what they didn't want, and they opted to have an amniocentesis at the fetal medicine unit, which was undertaken at 21 weeks, and the result confirmed that baby had beta thalassemia major. The couple then went to meet a consultant paediatrician at the Royal Manchester Children's Hospital to discuss the care of a child living with this genotype, as well as discussing lots of things that they'd read about and thought about, including possible stem cell treatment from their other child. At 22 weeks, the couple made the really difficult decision that they couldn't continue with the pregnancy, and she underwent termination in the local fetal medicine unit, and she went on to receive care from the screening and bereavement team. A second case I thought was interesting to mention was kind of other end of the spectrum, where we can capture, women early and kind of get them into screening early. So we had a woman who was referred to the Manchester Sickle Cell and Thalassemia Centre at 8 weeks pregnant by her hospital. She was living in a hotel. She had a complex social situation. She wanted early screening. It was important for her to know. She was being cared for by one of our specialist midwives because herself and her husband were seeking asylum. She had a poor obstetric history, given that she had 3 children who were reported to have died in Iraq in early childhood, thought to have died from complications from beta thalassemia. She herself had no living children. Because we captured her early, we were able to get her a test at the very first possible date, which the earliest we can do is 11 weeks. She underwent a CVS at 11 plus 1 weeks to ensure early diagnosis. We got a sample that day. She had a result by 12 weeks, which showed that the baby was a beta thalassemia carrier, but did not have beta thalassemia, and they were really pleased with that. That was a good news result. But subsequently, this lady miscarried 5 days following the CVS test, thought to be related to the procedure, although we're not 100% sure. And she miscarried. So that was, a really, sad case again for everyone involved. She has gone on to become pregnant again, but it just shows the difference of what happens when we screen and test early, although the outcome here couldn't have been helped. We had a woman who booked late last year for antenatal care. She was 29 weeks pregnant and had been in Nigeria. She was found to be a carrier for sickle cell AS. She was 30 weeks plus when we got her result. She herself was reluctant to engage because she had been tested in Nigeria and thought that she was AA, and she was adamant of that. She had a report to say that she was not a carrier of sickle cell. We offered her partner screening to try and ascertain the risk to the pregnancy. And although she was too late to get diagnosis while she was pregnant, we say we do the testing on the partner for information. It helps us to plan, whether the baby might be at risk when the baby's born. We would screen the baby after birth, or it can be reassuring, if partner's not a carrier, then sometimes that gives women reassurance during the pregnancy that this is not something that's going to come and shock them out of the blue after the baby arrives. There was reluctance again to engage, as her and her partner both didn't believe the results. She was offered a rescreen. We offered to test her again to be sure, but she declined. The lady's partner was actually unavailable for screening. He travelled from the Congo and was actually living in France. So the best we could do in this instance, although we like people to be screened here, as I said, it's not always possible, we encouraged him to try and get screened in France at a clinic or a hospital. The partner declined to be screened in France and said that it wasn't necessary because nobody in his family had sickle cell, and it wasn't something that was going to happen, it wasn't something that was relevant to him. In this case, we do categorize pregnancies as high risk. If we don't know the status of the father of the unborn baby, we let the newborn blood spot lab know that the pregnancy might be at risk, and that helps them prioritize the newborn blood spot sample when that arrives at the lab. So we completed the newborn alert form and sent that through. The baby was screened on day 5 of life by the community midwife at home, and at 12 days old, the mum was informed that the baby had sickle cell disorder. The baby was SS. The dad must have been a carrier and didn't know, and she was that. Baby had a 1 in 4 chance of inheriting sickle cell, and in this instance, the baby did. The role of the midwife, then, in summary, it varies, but in most, our role really is to support women and families throughout the screening journey and advocate for them where necessary. It's definitely to use the latest evidence-based practice and up-to-date information when supporting decision-making. That often means involving members of the multidisciplinary team to gain further insight or clinical opinion. If you imagine that the information you're giving as a midwife might affect the decisions they make about, the pregnancy going forward, we need to be really sure about the information we're giving about these conditions and what it means for children and young adults, and we often need the MDT to help us with that. It's to always provide a non-judgmental approach, regardless of views on termination or patient options or anything like that. It's to promote informed choice at every single stage and never exclude any potential options. Kind of don't assume that because one group might do this, that this woman is the same, or we won't mention that to her because she's doing this and she's from there and it might not matter. It's making sure all the information is available to them at every stage. And also, I think the role of the specialist midwife is to have a sound understanding of any external factors that might come into play, having appreciation for the individual nature of each case or patient. An example of this could be any specific religious beliefs or cultural practices, which may impact, decision making, and having a specialist knowledge around pregnancy and HBO disorders to be able to equip the patient to make decisions which are right for them and not for health professionals. So it's not, what anybody else thinks they should do. It's making decisions that they can live with and that they're happy with. And in summary, that is it. So thanks everyone for tuning in and listening. If you've got any questions, I'm happy to answer now, or I've put my email address and number on there if anybody would like to get in contact with us.
Thank you. That's great. Thank you, Della. That was really insightful and very informative. Do we have any questions from anybody, please? No questions? Okay. Well, as Della advised, she's shared her contact email address and telephone number there, so please do not hesitate to get in touch with Della. Oh, Peter, do you have a question?
Yes. Sorry. Yeah. I talked about knowing from previous pregnancy. I'm sorry. There's an echo. I don't know why that is. Anyway, so you talked about having women who you knew from a previous pregnancy that they had thalassemia or sickle cell or whatever trait. Do you get anybody who has tested before they become pregnant to know before, so they know before they conceive?
Yeah, good question, Peter. We do actually, and that many different reasons. Sometimes if women have had a screen outside of pregnancy and they know that, they may preempt their partners when they meet before they even go to get pregnant, to say, I have this is probably something we should look at, before we think of having a child or having a family, and they go and uptake their own screening, as I say, via a GP or a private clinic. We get women coming from IVF clinic, where if they go and get reproductive advice, they may have screened the partner before, just to be sure, so we know what we're letting ourselves in for before they become pregnant. And also, for example, the other day, I rang a lady from Cyprus. She was a beta thalassemia carrier. She knew about it because when she lived in Cyprus, she'd been screened because that's routinely done there due to the prevalence. And she said it was a requirement of marriage in Cyprus, and I've heard this in Turkey and Greece, that before you're married, you must show a certificate or provide that to your partner, so you both know before pregnancy, what you both are.
Can I just follow up if that's all right?
Yeah.
So I know in Iran they also do screening before pregnancy. So the question really is it common that you see people who have been tested before, or is it fairly rare?
I'd say the majority of people haven't been tested before. I think most of the people I contact, we end up undertaking the partner screening, but we do from time to time come across people that have gone down that road already and have results.
Thank you. And is it Ananda?
Hi, thanks, Della.
Okay.
Just asking the question. Like the first case you presented, the couple who knew, would you give them a pre-implantation genetic diagnosis in the subsequent pregnancies? Like, what will be the option for them?
Yes, we would. I'm not 100% sure about the criteria for PGD. I know for sure when they have no children, when they don't have any children. I think for the lady she already had a child who was unaffected, whether she'd be eligible for PGD. But PGD, yes, is something that we look at, and we usually refer to our genetics department for more information about that, and for couples to inquire about, eligibility for PGD.
Yeah, thanks, Della. I'll just step in and say that if you've had an unaffected child, then you won't be eligible for PGD the next time round.
Thanks, Nandini.
We also have Sean in the comments, who has asked if NIPT for these conditions is currently being considered by the National Screening Committee.
Yeah, another good question. I was previously from screening midwife background, screening coordinator, and we were heavily involved in the rollout of NIPT for trisomy. But as far as I'm aware, we haven't been involved, and we are a huge centre we haven't had any talks, or I haven't heard anything about if or when this may happen. So yeah, I don't know about you, Nandini. I've not had any information about prenatal screening in LPT.
Not yet. There are some discussions, but this is not rolled out as a national program yet.
Brilliant. So if that is all the questions, I would just like to thank you, Della, for coming on and providing this excellent presentation. If everyone, if possible, could fill in the survey provided in the chat, that would be really helpful and beneficial for us to provide future education sessions. And if anyone has any questions, please don't hesitate to get in touch with us or Della. We're more than happy to help. Thank you very much, everyone.